Welcome. Don't forget to subscribe to the channel and turn on notifications for new videos. Hello everyone. In this video we're exploring cheek region of the face, its boundaries, layers, and contents. Look at the buccal region. Here lies the most common mistake students make during exams. The superior border of the buccal region is the inferior margin of the orbit, infraorbital rim, which is formed by the zygomatic bone, the flat part of the cheekbone that forms the anterior part of the forehead. The zygomatic arch, that bony bridge extending back toward the ear, is not part of the buccal region. It forms the superior border of the parotid masticatory region behind it. Why is this important? Because the temporal branch of the facial nerve runs just above the zygomatic arch. If you mistake the arch for the buccal border and make an incision too high, you'll sever this nerve and paralyze the forehead. The lower border of the buccal region is the lower edge of the lower jaw. Laterally or behind is the anterior edge of the masseter muscle. Medially, or in front, are the nasolabial folds. Skin is thin, elastic, mobile. Contains numerous sweat and sebaceous glands. In males, may covered with fine hair along the lower border of the cheek. The sensory innervation of the cheek skin is provided by three main branches of the trigeminal nerve. The upper part of the cheek is supplied by the infraorbital nerve, a branch of the maxillary nerve, which is the second division of the trigeminal nerve. The middle part of the cheek receives sensation from the buccal nerve, a branch of the mandibular nerve, which is the third division of the trigeminal nerve. Finally, the lower part of the cheek near the mandible is innervated by the mental nerve, a branch of the mandibular nerve, the third division of the trigeminal nerve. Innervation is carried out by branches of the trigeminal nerve, sensory, and not the facial nerve. Here, it's important to remember Langer's lines, the main directions of connective tissue fibers. Incisions made parallel to these lines heal better and produce less noticeable scars, which is extremely important in maxillofacial surgery. Subcutaneous fatty tissue is loose connective tissue. Compared to other parts of the face, the subcutaneous fat tissue in the buccal region is particularly well developed. It bounded by a thin facial plate. The superficial facial mimic muscles, blood vessels, and nerves lie in the subcutaneous layer. The arterial blood to the cheek skin is delivered by branches arising from the facial artery. Venous drainage is accomplished via the facial vein, which ultimately empties into the retromandibular vein. Motor control of the mimetic muscles of the cheek is governed by the zygomatic and buccal branches of the facial nerve. For a detailed topography of the facial vessels and nerves, watch a separate video. Superficial fascia is thin connective tissue layer forming a sheath for platysma muscle. The platysma is a broad, sheet-like muscle of facial expression in the neck and face. It originates from the fascia over the chest and shoulder muscles. It then travels upward to insert into the tissues around the mouth and lower jaw. This muscle is innervated or controlled by the cervical branch of the facial nerve, which passes 1 centimeter below the edge of the mandible and does not enter the nerves of the buccal region. Its primary functions are to tense the skin of the neck and to help pull down the corner of the mouth, as in an expression of sadness or strain. The expression facial muscles of the buccal region are arranged in layers. The superficial layer includes the zygomaticus major and zygomaticus minor muscles. They originate from the zygomatic bone and insert into the modiolus and upper lip. Their primary function is to elevate the angle of the mouth, as in smiling. Deeper lies the risorius muscle. It originates from the parotid fascia and inserts into the modiolus at the angle of the mouth. Its action is to retract the angle of the mouth laterally, producing a tense grin or smile. Also, depressor and levator anguli oris for depresses and elevates angle of mouth. All these muscles are innervated by the buccal branches of the facial nerve. Facial nerve branches run in the deep layer of subcutaneous tissue and enter muscles from their deep side. Primary blood supply for the expression facial muscles comes from branches of the facial artery. The intermuscular cellular space boundaries are precisely defined. Laterally, superficial mimetic muscles. Medially, buccinator muscle covered by fascia. Anteriorly, orbicularis oris muscle. Posteriorly, anterior border of masseter muscle. Superiorly, zygomaticus major muscle. Inferiorly, depressor anguli oris muscle. The main content of space is loose adipose tissue. It is this tissue that, during inflammation, becomes the basis for the formation of phlegmon.Bishaw's fat pad, corpus adiposum bucci. Part of it is located in this space. It is not attached to the walls, but lies freely within the adipose tissue, which facilitates its migration during inflammation. The facial artery and vein, ETV, facialis, and their branches pass through or close to this layer. Important. In purulent processes, there is a risk of facial vein thrombosis. The buccal branches of the facial nerve, which innervate the facial muscles, also pass here. They must be preserved during surgical approaches. The parotid duct does not pass through the space itself, but rather on its outer wall, along the surface of the masseter muscle, separated from the tissue by a deep layer of fascia. However, in cases of extensive phlegmon, it can become involved in the process. The buccal fat pad, also known as corpus adiposum bucci or Bishaw's fat pad, is an encapsulated mass of adipose tissue located within the intermuscular cellular space of the cheek. Why is this important for a surgeon? Because this pad can serve as a conduit for purulent processes from one area to another. Buccal fat pad has three anatomical processes. Temporal process passes under zygomatic arch to infratemporal fossa into the temporal region, into its anterior, deepest part, under the zygomatic bone, along the outer wall of the orbit. Orbital process is located in the infratemporal fossa, adjacent to the inferior orbital fissure, through which abscesses from the cheek fat pad can penetrate the orbit and cause phlegmon of the retroorbital space. Pterygopalatine process through zygomaticomaxillary fissure to pterygopalatine fossa, which message to middle cranial fossa pterygopalatine process, is main route for pus spread from buccal abscess to cranial cavity, within 24 to 36 hours. Closely adjacent to the upper and lower jaws, the fatty lump of the cheek can be a route for the spread of purulent inflammatory processes of odontogenic origin, primarily developing in the jaws. Buccopharyngeal fascia is thin facial layer covering external surface of buccinator muscle. Continues posteriorly onto constrictor muscles of pharynx. The buccopharyngeal fascia is a deep layer of the capitis propria fascia, which forms a facial sheath for the deep structures of the buccal region, oral cavity, and pharynx. The fascia originates from the pterygoid processes of the sphenoid bone and the pterygoid hook. This is its strong bony anchor point. From here, it diverges in a fan-shaped pattern. Anteriorly and laterally, it covers the outer surface of the buccinator muscle, separating it from the superficial facial muscles, the pad of Bishah, and the buccal fat pad. This region is often referred to as the buccal fascia proper. Posteriorly and medially, it extends onto the lateral wall of the pharynx, covering the pharyngeal constrictors, and then continues into the esophageal fascia. This region is called the pharyngeal fascia. the buccopharyngeal fascia is continuous with the pharyngobasilar fascia superiorly and merges with the esophageal fascia inferiorly. Parotid duct penetrates the buccinator muscle deep to this fascia before opening into the oral vestibule. The buccopharyngeal fascia normally acts as a barrier limiting spread of infection from the buccal intermuscular space. However, when pus pressure exceeds facial resistance, infection ruptures through this fascia into the retropharyngeal space. The buccinator muscle originates posteriorly from the pterygomandibular raphe and anteriorly from the alveolar processes of both the maxilla and mandible near the molar teeth. Its muscle fibers run horizontally forward, converging at the angle of the mouth to blend into the orbicularis oris muscle. The motor innervation of the buccinator is provided by the buccal branches of the facial nerve, while general sensation for the overlying buccal mucosa is supplied separately by the buccal nerve, a branch of the mandibular division of the trigeminal nerve, which does not innervate the muscle itself. Its primary blood supply is the buccal artery, a branch of the maxillary artery, with venous drainage via the buccal vein into the pterygoid venous plexus. Topographically, its external or superficial surface is covered by the buccopharyngeal fascia. Notably, the parotid duct courses horizontally across the muscle's surface and penetrates it at the level of the maxillary second molar before opening into the oral vestibule. Functionally, during mastication, the buccinator compresses the cheek against the teeth to keep food on the occlusal surfaces. It assists in maintaining positive or negative pressure during blowing or sucking actions, and it works synergistically with the orbicularis oris as a functional sphincter of the oral vestibule. Clinically, damage to the buccal branches of the facial nerve leads to weakness of the buccinator, resulting in the accumulation of food in the oral vestibule during chewing, a phenomenon known as food pocketing. The innermost layers forming the wall of the oral cavity in the cheek region are the submucosa and the oral mucosa proper. The submucosa, or tela submucosa, consists of loose connective tissue that houses the minor buccal salivary glands. A critical structure traversing this layer is the parotid duct, Stenson's duct, which opens onto the buccal mucosa opposite the maxillary second molar, forming a small elevation known as the parotid papilla, plica ductus parotidii. A significant surgical risk in this area is that incising deep buccal abscesses with sharp instruments carries the danger of injuring the parotid duct, which can lead to the formation of a persistent salivary fistula. If you've memorized the boundaries, layers, and communication features of the buccal region, then you're doing well. If not, watch the video again to get an excellent grade in class. The anatomy of the buccal region is the foundation for safe surgical interventions in the maxillofacial region. Neglecting this information leads to serious complications: paralysis, widespread cellulitis, thrombosis, and cranial infection. Good luck!